respected senior professionals and dear friends, on one of the important topics of the diabetes, all-round intensification of glycemic and also non-glycemic benefits to live well with the diabetes. So it's a very big topic, but I try to give you an overview of this diabetes management in the next maybe 20 to 25 minutes. So in the next few minutes, I would like to talk on need for the all-round intensification. What about the combination therapy in the diabetes management? What are the recommendations for this combination therapy? Fixed drug combination therapy offering the benefits beyond the glycemic control. And the three drugs, the gliptins, the metformin, and SGLT beta combination therapy for all effective diabetes management, and few take-home messages. So you all know that diabetes is a very big problem. A lot of the people in India are type 2 diabetes, and in fact, India is the capital of the diabetes right now, surpassing the China. And if you see this slide, in 2019, there were 7.7 crores, and they project that in by 2045, the number will be 13.4 crores. But in fact, December 2022 itself, the number of the diabetics in India are to the tune of about 12.5 crores. So I think by 2024, so our number will be somewhere between 18 to 20 crores. So that is the genomic proposition. We are getting the type 2 diabetes in the society, maybe because of the obesity, physical inactivity, and unhealthy food styles, and sleep deprivation. So it is the 9th leading cause of the death, maybe the 2nd or the 3rd or the 5th, depending on the involvement of your comorbidities. So that is the reason, whether whatever the specialty you are practicing, so diabetes must be a very, very important public health problem to address all the medical specialties in India in particular. So even though we learn something about the diabetes from the undergraduates or the postgraduates or from the magazines or from the CMEs, but still 67% of the patients in India, they do not reach their HbA1c targets. You all know the targets of the diabetes, the fasting around 100, postprandial around 150, and HbA1c around 6.5. But it's very easy to say, but very, very difficult to achieve these figures in majority of our diabetic individuals because of the several reasons. So once you keep the blood sugars at a higher level, once you keep the HbA1c beyond the 6.5, we are inviting the complications. So there are the increasing complications and the comorbidities in patients with the diabetes. 1/3 of the persons with the diabetes suffer from the cardiovascular disease. Nearly 40% of the people with the diabetes suffer from the CKD, again a very dreaded disease with high mortality and the morbidity, with poor quality of the life, CKD. 88% of the people with the diabetes are overweight or the obesity, that's the metabolic syndrome. A lot of the people with the diabetes, they suffer from the macrovascular as well as the microvascular complications, a combination of the macro and the microvascular complications. That is seen in about 20 to 25% of the complications of the diabetes. So a lot of the people are having the CKD. Along with the CKD, they will have the non-proliferative diabetic retinopathy, and also they will have LVH, and also they will have a single vessel disease, the WSL disease, and with the past history of the TIA, and also some element of the neuropathy, etc. So that means that most of our diabetic individuals, they are living with both the micro and the macrovascular complications. So as I told you that nearly the 40+% of the people with the diabetes have the metabolic syndrome. It's a very big problem. 63% of the people with the diabetes suffer from the depression. See, if you see this slide, that shows that diabetes means not only your hyperglycemia. Diabetes means cardiovascular disease. Diabetes means kidney disease. Diabetes means retinopathy. Diabetes means overweight or the obesity. And diabetes means cluster of all these things, that is a metabolic syndrome. And diabetes means depression. So without addressing all these things, if you address only the hyperglycemia by seeing only fasting blood sugar and BP blood sugar, and you are making a lot of the nuisance to the patient, because these people will get the complications much early. So what I mean to say is, you should treat the diabetes in 360 degrees. Not only your fasting PP and HbA1c and the lipid profiles, etc. And of course, they didn't enter here. A lot of the people are also having the hypothyroidism. See the cardiovascular health in the patients with type 2 diabetes is the bidirectional. See the 2-4-fold rise in the concurrent occurrence of the CAD and the stroke. So diabetes means at least 2 to 3 times higher the risk of the cardiovascular disease and the strokes. 2 to 8-fold rise in increase in the risk of the heart failure. So again, I addressed several times the heart failure at this from this dais. Heart failure means 3 diseases in India. So the most common is ischemic heart disease, and then the diabetic, and then the hypertensive heart disease. So ischemic heart disease, diabetes, and hypertension, these 3 are the important reasons to cause the heart failure. And of course, with the heart failure, nothing can be done except the heart transplantation when the heart failure is the resistant heart. So managing diabetes may avoid or delay the development of the heart, blood vessels, kidneys, retina, and also the neurological diseases. Renal health in patients with type 2 diabetes. See, the diabetes is the leading cause of the kidney failure, according to the 44% of the new cases. And if you ask any fellow who is under dialysis or for the renal transplantation in India, there are only 2 reasons. One is diabetes, and the second one is hypertension. And unfortunately, both are the deadly duo. So when the diabetes and hypertension are responsible for most of the kidney problems, nearly the 90 to 95% of the people in India with the chronic kidney disease are either diabetics or hypertensive or both. So controlling the high blood pressure is a key factor in slowing this disease. This is the very, very important. So in all the diabetic individuals, you record the blood pressure by yourself and see whether the blood pressure is 120 by 80 or 130 by 80 or 140 by 90. Once the blood pressure is more than 120 by 80, so there is always a role to add ARB or ACE inhibitor in all the diabetic individuals to reduce your RAS blockade, to improve your RAS blockade, and also to reduce your sympathetic activity. And also, they may need a little bit diuretic also at a later time once the GFR is less than 45 or 30. So don't underestimate the value of the blood pressure in the diabetic individuals, because hypertension will increase all the complications of the diabetes. So unfortunately, this is a very, very common reluctance to increase the pill burden. Maybe some are the physician barriers and some are the patient barriers. See, as the diabetes is a progressive and the dynamic and aggressive disease, your treatment also should be progressive, it should be dynamic, and also it should be aggressive to reduce not only your blood pressure, blood sugars, and also your cholesterol, etc. See, the 9.5% global average HbA1c in the diabetic patients. In India also maybe 9.8 or 9.9 or 10. Even today, we see a lot of the people, they are new diabetics with HbA1c beyond 14, 15, 16. See, 4 days back, I have seen one patient from Amravati with fasting blood sugar 250, post-planned blood sugar 450, HbA1c 16, and the blood pressure is 180 by 100. Cholesterol, triglycerides is 1280, total cholesterol is 230, LDL is 180, so etc. and etc. So that means he is having diabetes, he is having hypertension, he is having dyslipidemia, etc. So only to get the sudden cardiac death or a cardiac arrhythmias. So fortunately, he has traveled all the way from the Amaravati to the Kakinada, and we initiated the insulin therapy, we initiated the fibrates, we initiated the statins, we initiated the ARBs, we initiated the calcium channel blockers, we initiated the vasoprotective beta blockers like your bisoprolol, and luckily he is all right and today he is discharged. See, a lot of the people in India, they are asymptomatic, even though they are having very high HbA1c, very high blood pressure, and very high cholesterol. So it is our duty with a strong family history of the people with a strong family history of the diabetes and hypertension and obesity, you check the blood sugar, you check the blood pressure, you check the cholesterol to give him a good quality of the life. See, the target HbA1c for the effective glycemic control is 7%, and my target is 6%. Why not 6%? Why not 5.7%? So 5.7 to 6.4 is the pre-diabetic, and 6.5 and above 6.5 is the diabetic. So you keep the target as close to the normal as possible, provided if the person is not getting the hypoglycemia. For example, elderly individual with renal failure, individuals with a lot of the comorbidities, okay, we will keep the HbA1c at 7.5 or even 8 also. But in young individuals without much comorbidities, when they are having the long life expectancy, and keep the HbA1c as close to the normal as possible to avoid the long-term complications. So the reason is the reluctance to increase the pill burden. So there are the patient concerns, and the physician's concerns. Patient concerns may be the cost, and luckily we are the happiest country in the world with the drugs price is very minimal. So the convenience is very important. Again, India is one of the beautiful countries in the world as far as the drugs are concerned, because we have a lot of the combinations. So we have the 2 drugs, 3 drugs, 4 drugs to improve their compliance. So the convenience is also very important, and of course the side effects. So side effect profile, every doctor should know the side effects of the commonly used drugs. For example, metformin. Don't start with 500 milligrams TAD or the 1000 milligrams BD in any diabetic individuals. Always start with the low dose to avoid the gastrointestinal side effects and slowly up titrate. In the same way, your sulfonylureas, don't start with the 2 milligrams or the 4 milligrams of the glimepiride on the day 1 or the Dianyl 1 or 2 tablets a day, because they cause hypoglycemia. Start with the lower dose, maybe 1 mg of the glimepiride or maybe 2.5 milligrams of the deba, or if you are glibenclamide or Dianyl, or maybe 2.5 of the 5 milligrams of the glipizide. In the same way, don't start with the gliptins, the sitagliptin 100 mg, BD or the TAD. A lot of the people they are taking BD, sitagliptin. No, sitagliptin is always a OD, 100 mg only maximum dose. In the same way, dapagliflozin only 5 to 10 milligrams, or empagliflozin maybe 10 to 25 milligrams. So don't use these drugs as the BD dosages. They have to use as the OD only. So these are very important. Every drug will have the side effect. Even our drinking water is also having a side effects, provided if it is adulterated. So the same thing happens with the any drug, but you need to know the side effects of all these OHs definitely. So now the approach to the combination therapy. See, as I told you, the diabetes is a dynamic and aggressive and a progressive disease. So you also have to give a combination therapist, because the pathophysiology of the hyperglycemia is the omnious octet. So it's not the fault of the pancreas alone. So pancreas not from the beta cells alone, maybe the alpha cells. Alpha cells release the glucagon, which is antagonist to the insulin. They cause hepatic glucose output. Maybe the intestines are at fault. Your liver may be at fault. Your muscle may be at fault. Your fatty tissues or your adipose tissue may be at fault. Your kidney may be at fault. So your brain may be at fault with the binge eating. So someone they may not happy with the one plate of this dish. They may need 3 or the 4 plates. That is the binge eating. So that is something defect in the hypothalamus, your satiety center. So when you are treating the hyperglycemia, when you are treating the chronic hyperglycemia like a diabetes, you need to understand all these 8 ways of getting the hyperglycemia and give the drugs, bombard the hyperglycemia or diabetes with these pathophysiological mechanisms so that you will be happy. So it is a combination that is the rule for most of our diabetes, because diabetes is not a single cause. A multiple causes are there. So far we know the omnious octet, and also dirty dozen causes also there, like your vitamin D3, etc. So aggressive glycemic control to reduce the complications. See, diabetes means aggressive management. Diabetes means aggressive, dynamic, progressive. So no doubt in it, because aggressiveness leads not only to an improvement in the symptoms and the short-term health, but also to the long-term. We are interested in the long-term complications. See, if you ask me the leading question that what is the most common symptom of diabetes, no symptom at all. 80% of our diabetes in the society, they are asymptomatic. Why you are giving the prescription for an asymptomatic individual? Because to avoid the long-term complications. So the complications may be the life-threatening. So in that way, you should be very aggressive. See, this is the UKPDS landmark study, very big study, started in the 77, ended at about 99, 20 years study. So it studied in the type 2 diabetes. They say that just 1% reduction in HbA1c will get a lot of the benefits in micro and macrovascular complications. See, our patients' HbA1c average is 9.7, 9.8. What is your target? Maybe 6.5. What is the difference? So 3%, 4%, 5% hike of your HbA1c. If you reduce the 1% HbA1c, you are getting about 30 to 40% of the benefit. So why don't you reduce the HbA1c by 2 or 3 or the 4%? What are the recommendations for your combination therapy? See, all these things: American Association of Clinical Endocrinology, American Diabetic Association, and American Diabetic Association and European Association of the Study for the Diabetes. So they say that combination therapy is the rule in most of our diabetic individuals. See, increase the durability of the glycemic. This is very important. So earlier, diabetes means glycemic triad. Glycemic triad means control fasting, control PP, control HbA1c. These are 3. Now the treatment is glycemic pentad. That means 5 things. What are the 5? First 3, fasting, PP, HbA1c, and then 4th one is the glycemic variability, GV. So use the drugs, keep the sugars, time in range. They should not cross beyond the 200. They should not low beyond the 80. So that means you should don't introduce the hyperglycemia or hypoglycemia in our individuals. So the blood sugar should be like a waveform. So if there are any spikes, either upper spike or the lower spike, upper spike will cause endothelial damage. When the blood sugars are very low, they cause the counter-regulatory hormones released like the cortisol. Again, they are also very detrimental to your vessels. So glycemic variability is very important. And the fifth one is the quality of the life. So these five are very important. Whenever you prescribe the diabetic prescription, you see that fasting should be under control, PP should be under control, and also HbA1c under control. And the fourth one is glycemic variability. Don't introduce high blood sugars or the low blood sugars. So avoid hyperglycemia, hypoglycemia, keep euglycemia. And the fifth one is the quality of the life. So potential impact on the medication burden, adherence, and the treatment persistence. Simultaneous targeting the multiple pathophysiological processes, complementary clinical benefits, glycemia, weight, cardiovascular. This is the very, very important. So whenever you treat the diabetes, you see A, B, C, D, E. A stands for A1C, that is your diabetes control. B stands for BP, your BP control. C stands for cholesterol, that is the lipid control. D stands for your drugs, your doctor's advice, and your diet. So the diet, drugs, and doctor's advice is the D, and E stands for your exercise therapy. So your exercise or physical activity. So unless you concentrate on this A, B, C, D, E, so you are inviting the complications in diabetic individuals. So most of the people we are concentrating only on the A. A means A1C or your diabetes control. So you have to think beyond the diabetes control in all the diabetic individuals to keep them happy, to give them good quality of the life. So this is our recommendations. So Research Society for the Study of Diabetes India. If glucose targets are not achieved with the two agents, start the third or the oral agent. If you are not happy with the three agents, start the fourth agent. If you are not happy with the four agents, start the fifth agent. You are not happy with all the agents, start the insulin therapy. So whatever may be the number of the drugs you are using, either single or the two or the three or the four or the five or the insulin. So don't bother about the number of the drugs you are prescribing, but please see that your fasting, your PP and postprandial should be under good levels. See, consider using SGLT inhibitors or the oral GLP-1 agonists. A beautiful drugs these two are. SGLT inhibitors and GLP-1 receptor agonists, they are cardioprotective drugs. They are vasculoprotective drugs. They are the renoprotective drugs. In fact, they are the best drugs to be prescribed for all our diabetic individuals to give them a good quality of the life. AGI, that is alpha glucosidase inhibitors, your O-glucose, your glenides, that is your repaglinide, or SGLT inhibitors may be considered, if not contraindicated, in most of individuals because they reduce the postprandial hyperglycemia very effectively because we eat a lot of the rice. Our rural Indian population, they eat a lot of the rice. So even though the book says that carbohydrate should be 50 to 60% in diabetic individual, the protein should be 1 gram per kg body weight, and fat should not be more than the 25%, your saturated fat should be less than the 7%, etc. So they are all the bookish. If you see the practicality, that carbohydrate content will be 80% or 90% or 95% of diabetic individuals. So there is always a role to use the drugs which reduces your postprandial hyperglycemia. So here the AGI agonists will help, definitely help. In elderly patients with an increased risk of hypoglycemia, all the elderly individuals, please beware that they should not get the hypoglycemia. In them, use a DP4 inhibitor like your sitagliptin or linagliptin or veldagliptin as an alternative to the sulfonylureas. See, sulfonylureas, they have the only one action. They bombard the beta cells to release more and more insulin. Whereas your DP4 inhibitors, they also act same like a sulfonylureas to act on the beta cells, but they also act on the alpha cells, they also act on the intestines, they also act on the brain, etc. In 5 ways out of your omnious octane, these DP4 inhibitors will act on the 5 ways to reduce your hyperglycemia. Now move on to the triple T therapy. Yes, benefits. So obviously, multiple pathophysiological mechanisms reduce the pill burden, improve the compliance. So they thought that they are taking only one tablet, but you are giving the 3 molecules in a single tablet. Okay, so obviously, once you use the 3 drugs, so obviously you reduce the glucose in a better way. So improved glucose control. See the third agent. So thiazolidinediones, your pioglitazone will reduce by 0.9%. SGLT inhibitors by 0.8%, D4 inhibitors maybe 0.6 to 1.2%, acarbose maybe 0.4 to 0.5 or zero point 0.6 is very high. I think 0.4 to 0.5 is the acarbose because they reduce only postprandial hyperglycemia. But we are not using the acarbose, we are using the voglibose because acarbose causes a lot of the gastrointestinal side effects like nausea, vomiting, flatulence, etc. Sir, మీదే వచ్చేస్తుంది సార్. HbA1c reduction and weight gain. So metformin, sulfurias, and thiazolidinediones. This is the very combination in our rural India. So your glucorid fort, your triglucorid fort, etc. So when you are using the three drugs like the metformin and sulfuria, like your glibenclamide, and your thiazolidinone, like a pioglitazone, HbA1c reduction is good because you are using the sulfurias, etc. But what about the weight gain and hypoglycemia? So weight gain will be there with your sulfurias and also with your pioglitazone. And whereas the hypoglycemia is there with your sulfurias. So suppose if you use the metformin plus sulfuria plus SGLT2 inhibitors, so the HbA1c reduction will be good and also the weight loss will be also there. Even the sulfurias, they cause the weight gain, but that will be nullified by using your SGLT2 inhibitors. So the no difference in the cardiovascular outcomes among the triple drug combinations. In this combination, suppose if we add the D4 inhibitors in the place of the sulfurias, what happens? So efficacy good as your sulfuria, but of course sulfurias will reduce the HbA1c by 1.5 to 2%. Even though the DP4 inhibitors will reduce the HbA1c by 0.9 to 1.2%, but you have an added advantage of no hypoglycemia, etc. In the Asian population, DP4 efficacy is comparable to the thiazolidinediones and SGLT2 inhibitors. So second and the third line agents for the fixed drug combinations. So this is the SGLT inhibitors with dapagliflozin, DP4 inhibitors with sitagliptin and the metformin. So with this combination, safer, rapid and sustained glycemic control helps reduce the body weight and also the blood pressure. There is the extra glycemic benefits. You can get it with the SGLT inhibitors because they not only reduce your blood sugars by blocking the reabsorption of the glucose from the proximal connective tubule. So they also gives your glucosuria, etc. Definitely they reduce the blood pressure, they reduce the body weight also. They improve the both insulin resistance and the beta cell function because you are using these drugs. So you are giving the some rest to the beta cells so that they gain more and more energy and reduce the pill burden. So improves the adherence and overall the cost effective also. If you use the single drug, so earlier SGLT inhibitor single drug is about 80 rupees and D4 inhibitor is about 90 or 100 rupees and metformin maybe the 2 rupees or the 5 rupees. So combination used to cost about 225 rupees a day. But now the combination is costing about Yantra Tarun. What is the cost of this? 19 rupees only. See the benefit. So cost reduction is very, very high. Earlier 200 plus, now it has the cost of 20 rupees. So Sitamet and DAPA, a good addresses all components of the Omnius octet. So if you see the Omnius octet, so the metformin, where it acts at the level of the 3 levels. So it reduces the insulin resistance at the level of the liver, at the level of the muscle, and also at the level of the adipose tissue. Your sitagliptin, where it acts on the beta cells, it acts on the alpha cells, it acts on the intestines, and also it acts at the level of the brain. Where the DAPA acts at the level of the kidney. So I think by using these three combinations, you attack all the 8 ways of hyperglycemia. So this is the best way of treating the hyperglycemia, chronic hyperglycemia, uncontrolled with your sulfurias, uncontrolled with your dapagliflozin alone, or uncontrolled with your metformin. So there is a role, I think at least 60 to 70% of type 2 diabetics, they need this combination before they move on to the insulin therapy. See the glycemic pentad, already I told you what I mean by the pentad. Quality of the life is very important. Effective glycemic control with this combination, good. Decreased by 0.5 to 8% HbA1c. Glycemic variability will be reduced, so thereby increases the quality of the life. So what is the clinical evidence? So a lot of the clinical evidences are there. So beyond doubt. So you need not read all these study details. You yourself is your own judge of noting that this combination is a very, very useful in our patients. So in one study, they studied about the 400 plus patients. age more than 18 years for the included here. See the HbA1c reduction, glycemic benefits, weight reduction 2.1 kgs. So dapagliflozin metformin combination. Primary endpoint, mean change in HbA1c is good. Once you are using the combination, so obviously you can reduce the HbA1c higher. If you use the metformin alone, so HbA1c reduction may be 1 to 1.5%. If you want to use the sulfonylurea alone, maybe 1.5%. In the same, when you use the combination, so obviously they also reduce the body appetite by using these combinations. Obviously, they also reduce the body weight, and definitely HbA1c reduction will be much higher. So need of the hour, a therapy that goes beyond the glycemic control. So which reduces the blood pressure, which reduces your cholesterol, which reduces your body weight. I think metabolic syndrome also can be addressed by this combination. So need for a therapy that goes beyond the glycemic control, a combination approach, both glycemic and non-glycemic benefits. Occurrence of the hypoglycemia or weight gain is very, very low. Need for the oral therapy. So you can avoid the injections, insulin for some time. So CV protection and the renal safety is established. So DAPA, you have the lot of the trials. So DAPA CKD trial, DAPA heart failure trial, and everything says that DAPA is a very, very useful drug. So nowadays, no, DAPA is a favorite drug to the cardiologists and nephrologists, even though they are non-diabetics. So why don't you take the advantage of this DAPA in our diabetic individuals? So when the fellow is present with the heart failure, so their compelling indication is to use the dapagliflozin. When the fellow is having the proteinuria or the early renal failure, even though they are the non-diabetics, so there is always a role to use the dapagliflozin in them. So in that way, when the fellow is a diabetic and with the proteinuria or with the microalbuminuria, etc., so definitely there is a role of the dapagliflozin in our population. So DAPA was associated with the reduction in the lower rate of the cardiovascular death or hospitalization for the heart failure. That is the very, very big advantage. Once you advise any fellow with the heart failure in an ICU, so the cost of the ICU therapy may be 2 lakhs or 3 lakhs. And always heart failure admissions are the there will be the recurrence of the admissions or the readmissions, and then the admission mortality is also very high. So that is the reason avoid the hospitalizations in any heart failure population by using the dapagliflozin. See, that's what the DAPA heart failure study. Worsening of the heart failure component of the primary event reduced by 30%. Very good reduction of the DAPA. CKD trial also very useful. See the primary outcome, sustained decline in the GFR by 39%, 40% reduction. Cardiovascular outcome trials, TCAS trial. SETA was not associated with an increase in the risk of hospitalization for heart failure in the TCAS, except unlike your saxagliptin. See, saxagliptin increases the incidence of the heart failure, whereas the sitagliptin won't increase the chances of the heart failure. In that way, it is not inferior to the any other. So safety, excellent. Also, there are fewer discontinuation rates of the hypoglycemic events. Lower incidence of the genital urinary tract. This is the very important point. See, when you use the SGL inhibitors alone, there may be the chances of having the urinary tract infections and the genital infections because you are causing the therapeutic glucosuria. So after initiating the SGL inhibitors, the people will pass the urine rich with the glucose. So the urine glucose will be 4 plus or 3 plus. So that means more and more glucose in the urethra. So definitely there is a chance of getting the UTIs and the monilial infections, especially in the women with the poor personal hygiene and the short urethra. But if you combine with the DP4 inhibitors along with the SGLT inhibitors, the incidence of the genitourinary infections and the monilial infections are reduced for some reasons. Hepatic safety, good. These two are good drugs. So perfect combination for all-round diabetes management. Effective control, lower risk of hypoglycemia. Omnious octet, you are attacking all the 8. Effective weight reduction is also there. Blood pressure control is there with the SGLT inhibitor therapy. Lower risk of genital urinary tract infection because you are combining with the DP4 inhibitors. Offers the renal safety and also the cardiac safety. So identify the patient's profiles who could benefit from the novel triple combination. See all these individuals. So in one fellow may be a CVD, one fellow may be CKD, one fellow may be proteinuria, one fellow may be the metabolic syndrome, one fellow may be the fellow with the hepatic failure or the fatty liver. So all these individuals will be benefited with this combination. So patients with uncontrolled type 2 diabetes, uncontrolled metformin and single drug or the double drugs always use this combination. Obese individuals, perfect combination. Cardiovascular disease, excellent. Chronic kidney disease, useful. So all-round intensification. Uncontrolled type 2 diabetes, you can use it. Uncontrolled type 2 diabetes with obesity, you can use it. Uncontrolled type 2 diabetes with CKD, use it. With CVD, use it. So CVD, CKD, metabolic syndrome, obesity, or simple uncontrolled type 2 diabetes, you can have this combination. This is the all-round intensification to make all our diabetes live well with the diabetes. So let us see their 80th birthday or 85th birthday or 90th birthday for all the type 2 diabetes with this excellent combination. So thank you one and all for your patient hearing. And if you have any doubts, I will be very happy to clarify them.